So, I am really delighted and honored to have been invited to speak today with some members of our team. Um, and I can introduce them. We had hoped to have a couple of other folks, but right now it's Sherry and myself. Um, so my name is Nitasha. I'm a family physician and who works in the Department of Addiction Medicine and Substance Use Services at Fraser Health, and have been privileged to be able to do some research work alongside that. And Sherry is the research coordinator on our team. I'll let you introduce yourself, Sherry.
Yeah, I don't have much else to add, but yeah, I'm Sherry, research coordinator on the team. I've been on the project since the beginning in 2023.
Today we're going to be talking about transcreation as an equity tool. We'll get into what that means, but that's sort of the title of our talk. Before we move forward, I definitely want to take a minute to thank our co-authors and collaborators who weren't able to be here with us today. So their names are listed here. Our patient partner is named Pendr Singh Khalsa. We had a student, Jasleen Badesha. We had other patient partners, Harinder Singh Sandhu, and then a couple of our other research staff are listed there below. They've been really instrumental in helping with some of the transcreation ideas. Before we also delve into the material, we want to acknowledge that we live and work on stolen and unceded traditional Coast Salish lands of the Katsi, Tsawasan, Kwantlen, Sonic, Cayuse, Umatilla, Walla Walla, Sami Amu, and Stolo First Nations. And apologies, I am still learning and trying to decolonize, so I may not have said those correctly or missed some names, and I will keep trying to learn. Um, as well, we are acknowledging that we're racialized settlers. And despite some of our experiences of racialization, we are still heavily influenced by white supremacy and colonial thinking. And so we're trying actively to learn anti-racism methods. And of course, the leaders there are Black and Indigenous community members and scholars. What we're trying to do right now, we've done a couple of things, is to take some courses. Some team members are taking courses on Indigenous studies, as well as we participated in something called the Asian Indigenous Relations Symposium, to try to further this relationship of racialized settler and decolonial work. We still have a lot to go. If we get started into the material today, we kind of wanted to set a bit of a context and we get our brains into the idea of language and what it means and how it's makes sense in our world. So, from our perspective, the language we use describes our world and it shapes our understanding of the world because of that. Um, if we were to kind of situate that in Canada, we know that we're a colonial state. We're trained and assimilated in the English and French languages due to that colonial past. And so, in that sense, our worldviews and knowledge are often quite influenced and shaped by English and Western words, concepts, and ideas. With that said, simply translating materials is not enough because when we take something from that colonial worldview and try to put it in a different language, we can lose things. And we have done a couple of studies in the preliminary work of our research that touched upon the experience that somebody who's not who has limited English proficiency might have. So this quote illustrates that for many immigrants, particularly Punjabi-speaking communities in Canada, access to linguistically and culturally relevant healthcare is often lacking, and there's a need for effective healthcare communication. And we furthered that kind of literature finding with some of our own interviews. So this is a quote from a woman that we interviewed that said, if it is a Punjabi provider, then you can speak openly, especially if you aren't comfortable with English. You can get a lot more help. Sometimes there are things you don't remember that you want to share, and it's easier to remember those things if you're speaking in Punjabi because our language is just like that, where we can automatically just remember. So that sort of sets the context, I think, of sort of the problem here that there's sometimes a lot of missing when we're translating things. Um, so a little bit about our research program as well, just to sort of set a little bit of additional context. Our research program is called the Rahi Research Program. Rahi means companion on a path in English and Punjabi, and it's meant to evoke a spirit of walking together. Our research activities consist of we've designed and are looking to do pilot feasibility evaluation of the Rahi Care Program, which is a intervention to support Punjabi families who are affected by substance use. We also work to explore and understand the experiences of addiction and recovery in the Punjabi diaspora. We are looking at the role of family in recovery, and we're trying to better understand the intersections between patriarchy, masculinity, and substance use, especially in this particular diasporic population, as well as setting precedent with research processes that are decolonial, anti-racist, and in particular, the transcreation process, which is what we'll talk a little bit more about now. When we first started the Rahi research program, these were some of our main research questions. So we were looking at social, emotional health, family relationships, trauma, social connections, and the linguistic influences in recovery. And just a little bit about designing the Rahi Care Program. We did a whole Punjabi Center design framework to co-design this intervention with all sorts of folks from the community. Over 50 people have designed it using participatory means. So that's one of the main things that our research program has outputted, if you will, from some of this work. And in order to complete this co-design, we really had to rely on transcreation because we were working so closely with members of the community who had limited English proficiency. And that learning translated, or like we carried it into the actual design of the program as well as the materials that we used for the program. So we'll talk a little bit more about that too. The program itself is like a 16-week program with two streams for men who use substances and then family members. So you can see on the left here is the curriculum for the men, and on the right is the curriculum for the family members. I'm just going to skip that. So I'm gonna pass it over to Sherry to talk more about transcreation.
Hi, thanks everyone. Thanks Natasha for the intro. So I want to talk a bit about the Punjabi Center design. So we were really lucky to have one of our first team members was Imro Singh Dill, who is actually the author of Punjabi Center Design. And Punjabi Center Design builds on existing design theories, but roots it into the historical social context of the Punjabi diaspora in Canada. And so the two key things that we really honed in on in that large thesis that he wrote was the box one and box two, which have guidelines on how to actually apply Punjabi centered design to working with Punjabi people. So, next slide. So, box two is kind of related to translation. So, talked about, these are kind of the steps that he had outlined. And because the work that we're doing is kind of circular in nature and community based, we were using kind of all of these steps in tandem. So, I'll kind of go through some of the main ones in the presentation. So, next slide. So, step one is setting up a base and assessing the cultural context. So, we did this in our team by doing exploratory qualitative interviews. Now, like Dr. Puri has already been working in this field for like 10 years. So, we already had that lived experience in our team. We also had social workers who work in Roshni Clinic, which is a withdrawal management clinic for South Asian people in Surrey. So we already had kind of that lived experience in our team, but also we did these additional qualitative interviews with 10 men and 10 women. We also did literature reviews, and then we started with our co-design meetings. So next slide. And so we realized that we don't have, like, there are people in the world that have more knowledge than us about translation. And so we started talking to those people as well. So some of the people that we talked to were obviously the people with lived experience, talking a bit more about like what are the barriers that you have when you're talking about like doing healthcare communication, or specifically substance use or family trauma type things. Um, the other thing that we used was Valencia Healthcare Translation, which is a translation service out of UBC. So we talked to their Punjabi team and got some feedback there. Imro Singh Deol obviously was someone that we connected with throughout this process. And then we also talked to counselors, because counselors are doing a lot of the translation of the language that we like, the words and ideas that we talk about in our prototype. Um, and we also had a person with lived experience who also had high proficiency in Punjabi, which we'll talk a bit more about in our next slide. So we built a diverse team of people who have experience. And so this is some of what the feedback that they gave us. So they said, like, log all the tough terms that you guys are coming across. They had some language adaptation, so how to like actually structure the words, cultural relevancy. What are some words that don't directly translate, but there might be something else, like a maybe like a metaphor, or like in Punjabi, we call them muhavra. I'm not sure what the word now is in English, but idioms. Design guidance, difficult term examples, translation approach, user testing, equity and knowledge, decisions. So these are all of like the feedback that they gave us. But of course, when you actually get into the work, you kind of realize that you're taking all of this knowledge, but you're kind of using whatever you can when you're right there and ahead of you. So next slide. So we'll talk a bit more about what we actually ended up doing. So this is like what it actually meant when we were actually doing. So making a glossary of key terms, translation of items by a team of bilinguals, reviewing and comparing translations, and negotiation of best items, and then consultation with healthcare practitioners. So next slide. So this is kind of what the glossary of terms ended up being. And we really want to thank the counselors for this, because they really gave us a lot of ideas on where to start, because we didn't have the contextual knowledge on like being a research coordinator, or like a translator, even a student translator wouldn't be able to have this context. So they were able to provide us some Punjabi expressions that were commonly used. Next slide. And so when we talk about building a team, we very quickly realize that there's a spectrum of language proficiency and also colonial influence. So we really had to look into ourselves and see and be very clear about how are we assembling the team based on fluency and capacity. So we found that our researchers had English fluency capacity, but they had very low Punjabi language capacity. Even though we can all speak it, we can all understand it, we can watch movies, we can even read some words, but we don't have the ability to actually write something like an informed consent form, or even like the prototype with much grace. So that's and the way that we figured this out was, if you can write a university level essay in either language, then we define that as having high capacity. So the key benefit of our team here was that we had a person with lived experience who also had very high language capacity that we were able to find, and this person was a third person who's not a part of our team but was looking at all of our translations and was able to give us actually ideas on how to do something in a different way. So one example that I can give you is a land acknowledgement. So we know here in Canada, like, we have a lot of words that might not be that are kind of here in the zeitgeist, but we don't know how to translate those in Punjabi. So if we say like, I'm a second generation racialized settler, that is something that we can understand because in the English language or in the context that we are now, but in Punjabi we can't really say that because there's not that context. So there's a lot of narrative explanation that happens there, or you actually have to talk to someone who has a high language, who has a high capacity that can actually think of a different way of saying that. So that was our kind of a way to assemble the teams. Next slide, please. Okay, so this is our iterative way of doing the translations. So when we did our co-design meetings with people with lived experience, they were all just them actually speaking out what they needed. And so it would be like myself or Dr. Puri writing notes, but actually us experiencing that and remembering and feeling and that visceral feeling of these are the ideas of what they want. And so I took that knowledge, and Dr. Puri took that knowledge that they had from ideas that they had in Punjabi and taking them into our research brains, which are heavily Western colonial influenced. And so we are, going to be using all of our English evidence to write these like ideas. So where if we're taking evidence from like CBT or anything else, all of the like even PubMed, all of this stuff is in an English worldview. And so that's kind of what we took because that's the framework that we're working within. So we took those ideas that they gave us and put them into this colonial Western worldview. We wrote the prototype out and then we passed it on to a translation service. But the translation service is also limited because they are also functioning from a colonial Western worldview because they're students who are being educated here in Canada. And the other thing is that um, they don't have much leeway into how they can change the language. So because they're contractors. So if we give them something, they can kind of translate it, but they can't actually recreate a new idea because by nature of them being contractors, they're kind of stuck. Um, so then the information comes back to me. So I'm again the bilingual researcher because I was there in the co-design meetings. I know what the people with lived experience wanted, and I could see the discrepancies between the translation and what we actually needed and the ideas that I was trying to get across. So I could pick up on all those discrepancies. So the next step that happened was I worked with a person with lived experience who also has high proficiency, and we sat and we reviewed all the terms that weren't making sense and sentences and rewrote them in a different way. And what this actually looks like is having a lot of conversations. So like there might be some words that aren't appropriate to use, but the other person who is the high proficiency translator, they might not know because of the context of this intervention. So it was a lot of communication of like, hey, this is actually where we're trying to get to. The last step is that it was reviewed by the 6 people with lived experience, the co-designers, and they confirmed that it was appropriate. So what happened now is we moved from a colonial Western worldview to the Punjabi worldview. And this is not to say that either of them are bad or one is better than the other, but this is how we were able to work with both of them together. And so this is kind of what helps translate our healthcare ideas into something that makes sense for people with limited English proficiency. Next slide, please. Yeah, so this is again just how we. So, what is transcreation? Transcreation is actually identifying an idea and then and working with that idea and having a conversation and building a new way to translate something. It's not a direct translation. It's an idea to idea translation, and so that requires a lot of refining and a lot of conversation. So, next slide, please. So yeah, so some of the techniques that you could use is like you could reframe it for a first person language. So for example, one of the words that is used is nashikori, which means addict in Punjabi, but then that's something that we had to have a conversation about. That no, for this context, we don't want to use stigmatizing language. We want to use first person language. Another thing was like another word was again using the shikori to describe substance use disorder, but we didn't want to use that word addict, so we changed it to a new word, which is nashe di bimari, which is disease of substances. So it doesn't, it's like a, you kind of have to have those conversations. So again, narrative explanation, a conceptual reframing, again having those conversations, and you can even do a partial translation. So it's a lot of the times there's some words that are, you know, even used in the Punjabi language that are English, so we use those words, and we just write them out in Punjabi. um, and again, doing the having the cultural context really helps because I am in I've lived as a Punjabi diaspora my whole life, so I'm part of this culture. But somebody who has grew up in Punjab or has that context has even more, so they can kind of help me help me differentiate between whether using a religious term is appropriate or not appropriate. Sometimes I might be substituting my religious understanding for culture. So because of how we're limited in our diasporic reality. So next. So I just skipped this slide, but this is kind of the last slide that I talked about, and these are just some of examples of terms of how we changed. So I'll just skip this one. I'll pass it back on to Natasha. Thank you, guys.
I hope you're still with us. I know this is like a lot. It's blown our mind for like the last 2 years, and it's been a lot of work and a lot of ongoing back and forth because we've been designing in Punjabi an intervention and then prototyping the intervention, writing up manuals and workbooks, and now we're also trying to study it with Punjabi people. So forgive us if it feels like it's all over the place. It's because it kind of is. But I'm going to try my very best to tie it up together in the last few minutes of our presentation with a few reflections on what we are trying our best to do and, obviously fumbling through as you as you may be able to see underneath all of our academic slides. Um, if we come back to the bigger picture again, language shapes worldview, and how people think about their health, how they think about wellness and recovery is influenced by the language they use. That's where we've started from. That's one of the main tenets that we have carried throughout this work. And so every time we're working with Punjabi folks, especially those with limited English proficiency, especially those who are immigrants. We have really tried to remember this, and translation is more than word for word equivalence. It's there to bridge conceptual and cultural gaps, and we're really trying to understand the Punjabi worldview on recovery. In addition, one of the other main like tenets that we've held on to is that health is embedded in culture. So concepts like healing, recovery, parenting, they all carry cultural meaning and are not just literal definitions. The final sort of tenet that we've carried through our reflections is that language, we believe, is also a determinant of health. And we've seen that directly from all of the experiences that have been shared with us, and the experiences we've had ourselves and in our families. Especially for immigrants in Canada, proficiency in English or French is obviously significantly related to health. And if there is poor proficiency, health could be poor. So we took all of those things and we have really tried to say that linguistic integrity underpins effective knowledge translation, effective integrative work, which ensures trust, engagement, and equity in healthcare and research too. Our particular learning edges, as you can see, are sort of really trying to take decolonial approaches to language and translation rather than what we're used to in the research world, which is sort of write in English, get a translation, try to even fact check, but not really more than that. And you can see from the way Sherry presented that loop, we're trying to take a bit more of a decolonial approach and recognize that it's important to give power and voice to people who are less colonized than us. So the bilingual contracted translator that Sherry has referenced multiple times is literally like an uncle in the community who's studied in Punjab, has a master's degree from Punjab, but we just thought, like this person has should be given more power and voice to the way that this material is developed and presented because that they're less colonized than we are. And it has meant a lot less structure and a lot more open-ended approaches, a lot more time. It has taken an inordinate amount of time. And recognizing our own levels of assimilation and colonization constantly. We've had to be as reflexive as possible because there's always power imbalances. We've done a whole other like talk and paper on like how we've used patriarchy as well because we're all women, but we're working on a project about Punjabi men and with Punjabi men. And patriarchy is huge and heteronormativity is huge in some parts of our culture. So just constant reflexivity and finding the ways to negotiate power and privilege with our different roles has been a part of it. And as I've already mentioned, transcreation takes a lot of time. So these have been our learning edges, and we've really had to throw some of our um, research structures and approaches out the window. And I really applaud Sherry, who's been like holding that tension very well. So if you want to learn more about that, I encourage you to reach out to her. She's taught me a lot. And some of the strategies that we've used to kind of continue this learning is like trying to center humility, empathy, focusing on connection, looking at ownership and not like we don't feel like as a researchers we have any ownership of this work, and we constantly remind ourselves of that. It's the community's work, it's not ours. We try to take the approach of the more the merrier. Like we have consulted a lot of people to do this work. And the other thing that we are doing a lot of is debriefing, checking in, having these conversations about how we're showing up, and then reading work and educating ourselves, again, as I mentioned earlier, about anti-racist, anti-oppressive, decolonial methods and principles, again, that are generated from community, because we can get lost in academia sometimes, but um, we're lucky that we have access to a lot of gray literature, not great, but they're both great too. But so the final thought, I guess, is that culturally informed translation and transcreation is a slow, equity-centered process that acknowledges positionality, acculturation, language proficiency, and colonial influences. And this process is essential for producing health materials and research that educates, resonates, and supports meaningful engagement for equity deserving groups. We feel that more research and precedent setting is necessary as we continue to evolve and diversify our healthcare and research landscape. And we're just so grateful that you were open to joining us today for our talk and sharing our learnings with us. So thank you.
Thank you, Natasha, and thank you so much, Sherry. I'm always so amazed when I hear about the work that you're doing, and I'm so inspired. So my impression is that you set out to develop the Rahi Care program, and yet you stumbled into this immensely impactful process of transcreation through that, which has the potential to impact so much of how care is offered within Fraser Health. So I'm just curious if process has been applied just within the Rahi Care program, or if you've used it outside of that program and if you've evaluated it. And yeah,
That's a great question. No, we have not taken this process elsewhere. I think we're just sort of feeling like we're getting a sense of it ourselves right now, but I'm hopeful that so what we have done is take it to the community. There are some community organizations that deliver programming to folks who are in recovery. And as we're trying to do the pilot feasibility work now, because we're planning to study it in that way, I think one of the aspects that we will try to evaluate is the, I guess, like transcreation pros, the way the transcreation is landing for native Punjabi speakers. So stay tuned, I guess, Alex. We don't have any of that insight yet, but I hope we would be able to present that at a maybe another year, in another year of this conference.
Yeah. Oh, we have a question from Lindsay. At any time, did you incorporate images or diagrams to aid in transcreation? Transcreation.
Do you want to take that one, Sherry?
Yeah, that's such a great question. I would say no, just because we were working with a lot of esoteric ideas, or maybe you could say social ideas that are about context. And yeah, so no, we didn't. But there are some diagrams that are used in the workbook, but those are more to aid ideas rather than like actually the actual transcreation process. So I would say no, but I can see that that would be a really good idea. So maybe that's something we should have done. But thank you for the question.
And I mean, that's referencing earlier work done in Fraser Health. I haven't actually looked at the literature body myself, but I know in Fraser Health, especially around chronic disease management, psychoeducation, and like kind of educational things. There's been a lot of kind of work done on the use of images and diagrams to share ideas. I know that it is actually used across Fraser Health to use diagrams. Again, though, and in some of the overdose prevention work, I think there is the use of diagrams to and 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 visuals to kind of share idea. But as Sherry mentioned, like we're talking about like communication skills in the Rahi Care program and like you know, trying to touch on ideas of like memory and how people remember their fathers, because that's like we're talking about patriarchy and we talk about like how to be a good partner to one another. So it's just stuff that is harder to depict some of those more complex ideas visually. But I really appreciate that suggestion too. Maybe we can bring that to our work. So thank you, Lindsay, for that question.
Well, thank you so much, Natasha and Sherry. It's been wonderful having you. I see we are at close to time. Yeah, I just want to thank you. And if anyone has any additional questions, I see that your email addresses are on the slide. So please do reach out.